Well, thank you so much to, first of all, Vasilios for inviting me to speak this evening. Second, thank you for your kind introduction, Kostas and Athanasios. It's so nice to see you both, albeit on the screen. I want to point out in my title that I have put in inverted commas that I'm virtually here. I would love to be there, but we are busy catching up with our waiting list, and I must seek your forgiveness. So Vasilios gave me this title, and I thought I'd apply the null hypothesis to this and do a large amount of reading so that I could come to a consensus, but I don't think I can actually produce a document. I can only give you a personal view. So let me take you through the evidence very briefly behind my thinking. It's absolutely clear that we have increasing sophistication in the mechanisms by which we can assess blood pressure, but the majority that are in clinical use on a daily basis, both in our offices and in the community, measure brachial blood pressure. And what we also know is that this gives us reliable and reproducible measurements as long as we keep our instruments well maintained and we apply the guidelines which are out there for accurate assessment of systemic arterial blood pressure. And we also know that over the last 50 years, we have had a large number of trials, some placebo-controlled, and some that have compared different classes of antihypertensive drug. But both designs have come to the conclusion that lowering brachial artery blood pressure is associated with an improvement in cardiovascular and cerebrovascular health. I've summarized these data just to capture this as an image from Fiona Turnbull's study in The Lancet in 2003. And what you can see is that we have placebo consider using anything else, such as central assessment of blood pressure. Well, the answer lies in the fact that the blood pressure in the brachial artery is actually higher than the blood pressure. It is also propelled forward by the elastic tissue constituents of the aorta into the peripheral circulation, so that the blood pressure is amplified as it extends outwards towards the hand. And that means that we are getting an over-assessment of the blood pressure in the aorta. But I want to emphasize the fact that most of the target organs affected by hypertension are very close to the aorta. So estimate of cardiovascular and cerebrovascular risk. I should actually emphasize on this slide that there can be a 40 millimeter difference in systolic pressure in the arm compared with the aorta. And I can take this argument a bit further, men in the dark columns and women in the light blue columns for over 5,000 individuals from under 20 to over 80. And this is the brachial aortic systolic pressure. So this is brachial minus. And you can see that there is this huge variation. So 20 millimeters between the brachial and the aorta in men under 20. But you can see that this variation goes right across the age range as one of the techniques which we can use to assess central blood pressure. So the important point to emphasize is that there is this difference between, on the vertical axis, we have brachial blood pressure, and on the horizontal axis, we have aortic pressure. And these data are garnered from 5,500 individuals. Now, what you can see here is that we have a group of individuals with what we would call normal or high normal brachial blood pressure, but actually there is a 70% plus or lost as assessed with a high normal blood pressure at the arm. So what we have to do is to assessments on the aortic readings. Now, as I've indicated, I want to just emphasize the fact vertebrals, so it's close to the aorta. The heart is behind the aorta, but obviously under increased pressure. If the peripheral vascular resistance is increased, then there will be an increase in left ventricular load and left ventricular hypertrophy. An increase in the central blood pressure will, of course, immediately be transferred to the brain, so there will be an increased stroke risk. And of course, the coronary arteries come off distal to the aortic valve, so that there will be a decrease in coronary artery perfusion pressure in diastole and an increased risk of MI. So what we have then is a compelling case for trying to assess central blood pressure. Mary Roman in 2007, in the Strong Heart Study Report, which was published in Hypertension, came to the conclusion that non-invasively determined central blood pressure is more strongly related to vascular hypertrophy, the extent of the prospective examination of the use of central blood pressure as a treatment target in future trials. And that is the telling statement. I've yet to find very much evidence of treatment targets and trials which have been carried out in the clinical. We can use a transfer factor to relate this measurement to what is exactly occurring in the aorta. So you can get your reading at the, say, the radial artery, or you can measure brachial blood pressure. You can apply the transfer function. Now, what this is an estimate, an algorithm, which has been derived from thousands of measurements. And what you can do then is to transfer the radial or the brachial from using the transfer function to give you an estimate of central aortic pressure. Now, in its own way, this sounds very tantalizingly attractive. But before we adopt this for everyday clinical practice, we should consider one or two caveats. Patients will vary in age, disease background, drug therapy, and heart rate variation. And I want to return to that in a moment. There is a marked variability of error at similar brachial pressures, and group masking of individual variability may be critical to its interpretation. I should add that, in fact, actually measuring the central blood pressure, the reproducibility over a long time period has yet to be, to my mind, convincingly published. I'm not rejecting this out of hand, but what I'm saying is, if you're going to have a transfer function which is applicable to a large-scale population, we must make sure it's reliable and reproducible. So what evidence do we have that central blood pressure may be of interest and therapeutically important? Well, I want to take you back to an outcome study which was called the ASCOT trial. Receive an atenolol-based regime or amlodipine-based regime. And then throughout the course of the study, there was a mean reduction, a difference of nearly 3 millimeters of mercury in favor of treating the patients with amlodipine. And in fact, the primary event rate was reduced in amlodipine-treated patients compared with beta blockers. Now, Brian Williams and his colleagues took a sub-study of the ASCOT trial and measured central blood pressure. So the hypothesis was that the different blood pressure lowering rate, the difference was only 3 millimeters systolic on brachial blood pressure. And the secondary hypothesis was the derived, I've put this in green, central aortic pressures would be an important determinant of clinical outcomes in ASCOT. Remember that the only way we can get direct information on central blood pressure is to insert a catheter, so we must apply the transfer factor. So what this study has done is taken a subset of patients in whom brachial blood pressure has been measured, applied the transfer factor to derive their central aortic pressure. So here are the data. So here we have the peripheral systolic, that's the brachial systolic pressure for amlodipine and for atenolol. And you can see, as I said before, there was this very small difference in systolic blood pressure, and highly significantly so in this subset of the population of ASCOT in lowering central blood pressure. And of course, the events were reduced. So here is the primary event, the composite outcomes in ASCOT, and there is the highly significant reduction. Amlodipine plus minus perindopril-based therapy was more effective than atenolol plus minus thiazide-based therapy at lower central aortic systolic blood pressure and central aortic pulse pressure, and also that brachial blood pressure is not always a perfect surrogate for the effects of drug therapy on central aortic pressure. But this is very interesting. What would have been the outcome were a correction made for heart rate? Because the beta blocker treated patients will have a slower heart rate, which will have aortic pressure. So I asked one of the CAFE investigators whether they had considered correcting the data for the change in heart rate, and they decided not to because it might spoil the story. Well, we'll wait and see whether somebody will do this on a post hoc basis. So what else do we know about deriving central blood pressure which may be interesting? There is a large wealth of data suggesting that ACE inhibitors will reduce central systolic pressure. Variable data on angiotensin receptor blockers, effective diuretics, and a marked effect of nitrates. And the take-home message is that different classes of drugs seem to have different effects on central blood pressure. And if we were to adopt central blood pressure as a therapeutic measurement, then we might actually tailor an individual's blood pressure based around the efficacy on central aortic pressure. I've completed my presentation and I have come to the following conclusions. Accurate assessment of central blood pressure is an attractive advance in cardiovascular risk assessment. At present, the long-term reproducibility and accuracy has yet to be firmly assessed in my view, but in the longer term, were it to be so, then the indirect measurement of central blood pressure with instruments such as sphygmocore or applanation tonometry might well be therapeutically attractive. Central blood pressure can be measured, as I've said already, but we are reliant on an indirect measurement for obvious reasons. Large-scale trials are still needed to demonstrate clinical utility, and therefore my conclusion is that I do not think we will be introducing central blood pressure assessment in